In Professor Liao's study, he provided the first milestone evidence that antiviral therapy with lamivudine could reduce 51% of HCC risk in 3 years. In Professor Su Dong's study, the results are the same with anti-COVID therapy. In comparison, the study from Japan and Hong Kong, the results with anti-COVID treatment in 5 years are the same, but there is no significant evidence to treat non-cirrhotic patients in 5 years. Professor Wu Jinyun nationwide population study, he reported there is 63% reduction of HCC risk. The benefit could also be extended to young age people and the non-cirrhotic patients. In the recent international multi-center study, including Taiwan, there is a significant evidence that antiviral therapy or TDF in 8 years could reduce the HCC risk in both cirrhotic and non-cirrhotic patients. So in a short summary, most studies reported positive effect of NUC therapy for liver cirrhosis in 5 years. But only small and usually insignificant HCC reducing effect of NUC in non-cirrhotic patients in 5 years. So it is not easy to perform meaningful comparison between treated and untreated patients. So we need large number study and a longer follow-up period. How about the positive versus negative variables to patients' outcome in treated patients? In Professor Su Dong's study, there are 5 prognostic factors in the cirrhotic patients. It is their age, male gender, e-antigen status, alpha peripherin levels, and the virological response at 1 year. In Professor Xu Yaojun's study, there are 4 independent factors such as age, mass score, gender, and diabetes. And diabetes carries the highest risk. In Professor Cai Mingzhao's study, the important factors are age, platelet count, use of statin, and the presence of varices. Varices carry the highest risk. In Professor Wang Jinhong's study, age and the liver stiffness are the important factors to predict HCC in cirrhotic patients. However, the dynamic change of liver stiffness could not predict the HCC exactly. In Professor Peng Chenyuan's study, anti-COVID therapy in 5 years, the risk factors are FIB-4 at 12 months and the dynamic change of FIB-4 in non-cirrhotic patients. They are the same in cirrhotic patients, but in addition to FIB-4, there are also gender, diabetes, and the alpha ferroprotein factors. How about the tertiary prevention? In our previous study, patients received liver resection with high HBV viral load had a higher recurrence rate and a shorter survival in untreated cohort. In Professor Su Jianwen's study, antiviral therapy could reduce the HCC recurrence rate and improve overall survival. In their analysis, there are also other prognostic factors such as multinodules, macromuscular invasions, cirrhosis, and so on. However, they did not analyze the risk factor in treated patients. In Professor Wu Junyin's population-based studies, there were 33% reduction of HCC recurrence and improved overall survival rate after antiviral therapy after liver dissection. The benefit could also extended to other cohorts for young age patients, female gender, a lung cirrhotic patient, and a patient with or without diabetes. So in the short summary, host factors such as age, sex, fibrosis, hepatic dysfunction, or diabetes are major HCC risk factors in treated patients. The dynamic change levels of serum markers are also important. But more risk-associated factors could be identified in large and long-term studies, such as liver cirrhosis. Additional strong risk factors, such as pathological findings, were found in tertiary prevention. However, the hotspot, is there any difference between ETV and the TDF? The CHOSE study from South Korea reported treatment with TDF had 32% more reduction of HCC than anti-carrier treatment in both population-based and hospital-based. They also report the benefit of TDF treatment in tertiary prevention. There are 21% more reduction in early recurrence and 32% more reduction in late recurrence. The pathological risk factors could only predict the early recurrence of HCC. After the report, there are a lot of debates of study to discuss the issue. In Professor Xiaojun's study with a matched cohort, international multicenter, in 5 years, there is no difference between two drugs. There is also no difference in the recent study of Caucasian population in both compensated cirrhosis or no-cirrhotic patients. The study had much more TDF patients and a much longer follow-up periods. So the logical hypothesis is that various factors could have positive or negative effects on patient outcomes, such as age, gender, diabetes, breast, and liver cirrhosis. They are always good guy and the bad guy. However, approved treatment as ETV or TDF should always have a positive effect. They are all good guys. So the distinction between two treatments might arise from very subtle difference. To establish this subtle difference requires large-scale statistical robust studies. Maybe in high incidence rates liver cirrhosis patients. In addition, meta-analysis might have scale-up studies. We have conducted 5 years comparative risk of HCC in treatment-naive compensated liver cirrhosis patients. You can see that in 5 years treatment, there is significant difference in all the patients. However, the difference is no longer significant after matched cohort. The important factors include platelet count, alpha ferroprotein, diabetes, HCC family history, and the presence of upper GI viruses. The treatment choice is significant only in univariate, but not in multivariable analysis, stepwise analysis, propensity score adjustment or propensity score matching analysis. However, if we extend the follow-up period to 7 years after 2011, there is significant difference again, even in matched cohort. But the case number in TDF group is much fewer after 5 years. So Professor Huang Yixiang's study, they enrolled liver cirrhosis patients between 2011 to 2019 of multi-center study with matched cohort. In the univariate study, there is significant difference. However, it is no longer significant after multivariable analysis. In the recent collaboration of 3-center study by Professor Chen Jianhong and Peng Chenyuan, they also report significant difference for all patients, even in matched cohort. But if we limited the comparison in compensated liver cirrhosis patient, it is no longer significant. So there have been 10 meta-analyses in recent 2 years. You can see that some reports prefers TDF treatment for all patient or subgroup analysis. However, there are also reports think they are equal. In the joint study from Hong Kong, it is only different in cirrhotic patients, but not in non-cirrhotic patients. In this study, the difference only significant in risk ratio analysis with cumulative incidence rate statistical method, but not significant in only hazard ratio studies or risk ratio with annual incidence rate. In their study, the difference also existed in naive patients, not fully cirrhotic patients, longer follow-up patients, Asian people, and the high-quality literature. In the depth studies, the difference was only significant in adjusted database, but not in an unadjusted database. In the study of Professor Zheng Zhaohao and Xu Yaojun, it is the second largest meta-analysis study until now. They report that there is no significant difference, no matter the database is adjusted or not. It is not related to the status of liver cirrhosis or not. Even though there is a trend of significant difference in the administrative database or electronic database, but it is not in clinical cohort database. The only significance existed in the population studies with longer follow-up period of anti-caviar. So, ladies and gentlemen, in conclusion, in studies, it is easier to observe the effect of a treatment versus no treatment in patients with a high risk of liver cancer, such as liver cirrhosis. Similarly, it is easier to determine positive or negative variables to patient outcome after treatment in high-risk patients, such as age, gender, diabetes, platelet count, FIB4, varices, and so on. There are still conflicting results in the literature on the role of TDF or ETV. The reason might be there might be subtle difference between two agents? Maybe not. And the major factor is the length of the follow-up periods have not been consistent. It is the most important, because entecavir was always with larger patient numbers and a longer follow-up period. And serotic or not seems to be also controversial, even they belong to high incidence rate of events. So we need a randomized control study to answer the question, but it seems impossible right now because TDF been replaced gradually by the new generation drug of TAF. Thank you for your attention.